I think we're going to move on to some questions. Okay, is there any questions in the room?
So Sue Kemsley, GP in Cheshire. I just wanted to know whether you involve GPs directly in your MDT meetings, and if so, how? I'm happy for any of you to answer that.
I'll take that on, because funnily enough, I've just been having that conversation with a GP in my area this morning. No, the answer is no currently. The MDTs that we undertake tend to be with cardiologists and with other specialist consultants, mostly because we've always had really strong relationships and speak one-to-one with the GPs who are managing the patient's care. But I was talking with one of my colleagues who's going to be speaking shortly, and we were talking about this very issue this morning. This is definitely an area for expansion in community that we should be inviting GPs into the MDTs, because we all have an equal stake in managing these patients, and often the things that we are not sure of that may not be heart failure can be picked up by the primary care physicians. So I would say at the moment we don't in our service. I can't speak for every service, but I think it's definitely something that we'll be looking to develop.
I think that often also works the other way around, because I know that I've never been invited to an MDT in where I work now, where I worked in Cheshire. I would be if that patient was known heart failure with other comorbidities and it was a discussion in the practice. And I think it's a two-way sword, that really, isn't it, in the fact that yes, you need to be involved in the MDT because solely that patient will come back into your care at some point. But the same principle is you need to tap into us to be part of the MDT when you're talking about them within your primary care setting as well. I think that's something definitely that we need to move on with, yeah.
I think in our local heart failure MDT at Liverpool Heart and Chest, we do involve GPs. Dr. Stuart Bennett attends our weekly heart failure MDT. And having worked in community heart failure as well, I have been to GP MDTs, like the GSFs. But again, I think the same as what Diane's saying there, that's a two-way thing. I don't think we get invited to enough of the community GP meetings.
I think historically GP MDTs are all about cancer patients, and heart failure has not featured as high as it should, and I think that's certainly something that needs to change.
Thank you. Sorry, another question there.
It's just along the same lines. With all the CCGs dismantling and going into sort of a new sort of service, do you see the others being involved? Where I am, I'm at Knowsley currently. I think there is a primary care service, but again, the GPs aren't actually involved in the MDTs. Do you see the picture changing, the landscape changing beyond next April? Maybe you're not the right person to ask, but
I don't know if any of my colleagues feel.
Yeah, what I find is, in the knowledge that I have with the primary care networks, there seems to be every primary care network has its own idea of where it needs to run with heart failure, and they vary a huge amount. So if we're going to work this forward nationally, that we're all trying to say things from the same sheet, we're all given the same opportunity so our patients actually are treated equitably, then I think the primary care networks can't do things solely, and that seems to be the picture that's coming out from where I work at the moment, is we've got a primary care network who's choosing to say heart failure, but they want things within their own practice versus someone else who wants to make sure they can refer in to our services. So I think, we just need to be very mindful that, we're not making a postcode lottery in this as well.
Rajiv, are you going to talk us through the questions on the app?
2 or 3 online questions. So one is for Zoe. Across Cheshire and Merseyside, what's the average wait time? Sorry, Zoe, you may or may not know this. It's for the whole of Cheshire and Merseyside. Sorry to put you on the spot. What's the average wait time for patients to be seen for their first appointment in cardiac rehab?
Well, thanks for getting me out with that one. That's great. No, it is obviously really difficult across the patch, but because again, going back to the NACRA data, we don't particularly collect that data as an audit, which probably we should do. We're asked to collect that data for post-MI patients and for bypass patients about how quickly we see these patients. But now we're getting to know that we should see heart failure patients as quickly as possible. I can speak for my service, and then hopefully my colleagues will back me up that we see them pretty quick, hopefully within a week. So if they're referred, any point we can triage, phone the patient and offer them the next available appointment, which is generally within a week. And that appointment would consist of a specialist cardiac nurse and an exercise test. And then from that day, they would embark on some type of of exercise rehabilitation.
One more question is about how COVID has impacted each of your job roles. What have you seen? Any positives out of it? Have you had to modify how you work?
I know that we changed a huge amount. We were one of the very lucky services, heart failure-wise, that we weren't disbanded, we weren't sent anywhere else. We kept our whole team through the whole of the pandemic. And due to that, we were able to still utilise just different ways, BP monitor loans. We were able to take in some and skill up band 5s to go out, and also even putting on 24-hour tapes in patients' homes. Those sort of diagnostics were able to be done. So I think we changed quite a lot in the way that we could review patients through telephone as well, because it's always really been face-to-face initially. But a lot of patients were able to do that, and we now have telehealth, which is a huge impact. So those patients can be monitored at home, and we just get the alerts coming through. So I think in certain areas we've been very fortunate in the fact that we've grabbed it by the horns and been able to do so. And in other areas, I think we'd all agree that roles were redeployed elsewhere, and so those patients were sort of left adrift. But they're all coming back online again now. We're all back.
I think from a community point of view, we are not attached to a hospital, so we're a community trust. So we were lucky in that we weren't disbanded. The trust were very keen for us not to get out seeing patients, but unfortunately, as you know, heart failure patients, quite difficult to diagnose over the phone if they can't speak. They're so breathless they can barely walk to the phone. So we maintain patient contact mostly for the patients that were acutely decompensating to avoid hospital admissions. The hospitals were under enough pressure without avoidable admissions for decompensating heart failure patients. All the community clinics were shut down, as all NHS non-essential buildings were, but we continue to, as Diane says, remote embrace the technology. So there was video and phone reviews. We used patient staff who were isolating. We tapped into them as a resource for senior staff doing telephone reviews. And we did what we could really to make sure that we at least were able to stay in contact with the patients and try and early identify any change in their condition for those that we weren't able to actively review and titrate. So it was ups and downs really, but I think some of it, the advancements in technology and patients being able to embrace stuff that they were perhaps resistant to before has been quite good. That's probably a small positive.
Thanks. I think along with that, there's a question about complex device diagnostics and how that is integrated, say that information being available in the community more readily to prevent that crisis admission.
So, I mean, I could talk about this, I suppose, because I work with Archie and Rachel, and we've been doing a trial for the last few years with a system looking at having community-held clinics within the Medtronic network where patient alerts are relayed to us. We're able to then contact the patient at home and have a chat with them, see if their symptoms match the alert status and identify early changes, which has been, it's been an interesting journey. I think Archie will say it's been ups and downs, hasn't it? It was a slow take-off, but we are embracing that technology, and it's certainly, for us, in the community, it's just another tool that really helps us. And I think, again, for the tertiary care centres, it's a bit of a link with the patient that perhaps you didn't have before.
I think the patients are amazed, aren't they? When
They're
you
fascinated by it, aren't they?
I'm just ringing you to see if you're breathless because we've had an alert. They're like, what? How do you know? It's one of those. So I think, it is a really good system.
Magical.
Thanks. I think there's just one more point being made about MDTs. It's very important that the primary care physician is part of it, and even the patients themselves. I'll just give some perspective about the difficulties, because we've run a multi-speciality MDT for about 2 years now. We've had GPs as a part of this on and off. The difficulty is about 20-25 patients are discussed as part of this MDT. So people pitching in, pitching out for a 3-hour period is difficult, but that's something that is absolutely essential. So as we all agree.
And can I just mention the top one? Thanks about heart failure nurses for Christmas. I just wanted to say that, heart failure nurses have always been sort of not looked at in the fact that we are very expertise in many ways from different CCGs. And now we have the National Competency Framework. It's allowing all the heart failure nurses to have something to work towards, to help build business cases throughout their own trusts. And I'm hoping that using that will help us move forward as a huge team to say that this is what we deserve.
I think just to add to that, I think it's incumbent in existing heart failure teams to look to develop and train the next generation of heart failure nurses, because at the moment when there's a heart failure vacancy, it's the same 25 staff moving around the region. So we could do with some new ones.
Thanks. I think Gavin there. Thanks to Gavin as well for patiently waiting. But he's a perfect example. You know, he's advertised well enough for more heart failure nurses, more heart failure pharmacists, more rehab. So I think that should be a part of all our Christmas wishes. Thanks, everyone. Thank you.
Thank you. Thanks,
So I think
Gavin.
we'll move to lunch now. Thank you, everyone.